Hello everyone, this is Ms. Gerald and I'm going to be discussing quality improvement. Now, during this PowerPoint, you're going to see a lot of slides that we've discussed before in 111, and that's okay because it is essentially a review with the exception of us diving deeper into core measures and some concepts under the benchmarking process, okay? So who is responsible for quality improvement in the healthcare setting? And I hope your answer was everyone, because everybody plays a part in the quality improvement, including the patient, right? So one way in which nurses can provide high quality care is to participate in a continuous quality improvement program. Not necessarily nurses, you have to be a nurse that works in the quality department, because the quality department is every department within the hospital, okay? Your quality department, for those nurses that work in the quality department, they just oversee it. But as future registered bedside nurses, everyone is responsible for quality improvement. So the department or the unit in which you work is a quality department. Do you understand what I mean by that? It should be the care that we provide for patients should be a continuous, quality, safe, efficient care. The care that was intended to help patients should not harm them. So just understand that as we go along this semester, you're going to be learning to do more in-depth procedures such as starting IVs, monitoring chest tubes, central lines, and just think about the process and the protocols that are in place for these interventions that you're going to be doing for patients, and if steps are omitted, how that can cause harm for a patient. For example, if you start a IV and you don't scrub the skin, you can be introducing the bacteria that's on the patient's skin and introduce and put that same bacteria in the bloodstream, because you failed to adequately clean the patient's skin before starting the IV. So don't just get caught up in doing procedures and not really realizing the quality and safety behind why you are doing the procedure and how important it is to follow policies and procedures. Okay? Here are your student learning outcomes. I'm not going to read those for you. Again, you know how I feel about student learning outcomes. If you know how to look at these outcomes as questions, you can really have a solid working knowledge and be able to answer questions surrounding this concept, as well as when you're practicing in the clinical setting. One outcome I will talk about is learn to cuss, and we'll talk about that later on in the PowerPoint, exactly what that means and how important that is. Okay, I'm not going to read the other outcomes, but I know you probably looked at that last one and said, oh my gosh, what is that? Yes, you do need to learn how to cuss in healthcare for your patient. Okay. Who is responsible for QI? I just said that, everybody. I look at this cartoon and I said, you know, that's how nurses look at it. Oh my God, another quality improvement campaign, just what we need. Yes, quality improvement is what we need, and we shouldn't look at it as it's something that's going to make us work harder or something else we have to do. It's just what we get to do for our patients. So you see the difference. Don't look at quality improvement as, oh my gosh, it's just something else we got to do. No, it's something that I get to do for my patients. I don't want to, as a registered nurse, I don't want to cause harm for my patients. I don't want harm to come to me if I was a patient or my loved ones, okay? So just keep that in mind. All right, the 6 aims for improvement. Everything that we provide in healthcare, we should aim for these 6 concepts. We should aim for safety. We should aim for providing safe care for our patients. We should aim for avoiding injuries to our patients, okay? That is the first and foremost. So when you see NCLEX questions, of course, always think number 1, safety. When you're out there providing care for patients in the clinical setting, first and foremost, always think safety. We should aim for safety. Every hospital should aim to provide a safe platform or a safe environment for patients. Excuse me. Effectiveness. We as healthcare providers should aim at providing effective care that is based on scientific knowledge. Everything we do in healthcare, every interventions that we do in healthcare, coordination that we do in healthcare, it should be based on scientific knowledge, evidence-based to support why it is that we do. For example, why do we provide pericare before we insert a Foley catheter? Because it decreases the chances of infection, right? So why do we monitor a patient's apical pulse or pulse rate or blood pressure before we give a blood pressure medicine or heart medications? We want to keep the patient safe and don't cause the heart rate or the blood pressure to go down further if it's already low to begin with. That's based on evidence. So our care should be effective. It should provide a benefit for the patient, the services that we're rendering, okay? Our care, we should aim for patient-centered care. Okay, we're always providing care that is respectful and responsive to patients and families. We should always ensure that our care is keeping in mind the patient's values, the patient's culture, the patient's religious preferences. It should be geared towards the patient. It should be patient-centered care that drives all of our clinical decisions, okay, that we do. When does this patient want their medication? When does this patient want their help with their AM care? We should be providing patient education continuously. That's patient-centered care. That is a part too of your QSIN. Always education. Patient needs to be educated on everything that is done for them. That's patient-centered care. That's one of the areas that you guys really miss with your QSIN is your patient education. That is patient-centered care. We should aim for delivering timely care. We should reduce wait times in communicating critical labs to our physicians. Okay, it should be timely care. We should administer our medications on time for patients. So just think about that. We should aim, these are 6 aims that hospitals should be striving for. Our care should be efficient. We shouldn't be wasteful of medical supplies. We shouldn't be wasteful of how we take care of our equipment. You know what? And we also, as nurses, should not be wasteful of our ideals. Nurses, nursing students, you have great ideas. You shouldn't be wasting those ideas. Those ideas, if you have an idea as a registered nurse that can help make your unit run better, that can be something that will help the patient, then speak up. Don't waste those ideas, okay? And I think I shared with you in 111 how I had one of my former nursing students came up with a great idea in the clinical setting that will help decrease the spread of MRSA on a unit by using the dry erase markers on the communication board, by keeping a dry erase marker in every patient's room, and the dry erase marker gets terminally cleaned with that room at every discharge. And so the dry erase marker is not shared from room to room and not being cleaned, especially on your patients who are on contact isolation. That's efficient care. That idea was not wasted. And of course, lastly, care should be equitable. We should aim to provide care that is fair across the board, regardless of a patient's gender, race, their religion preferences. And I'm going to tell you guys, another one that we should be mindful of is taking care of patients fairly regardless of their diagnosis. I should take care of a patient who has a diagnosis of AIDS, HIV, the same way I take care of a 90-year-old patient who has dementia or high blood pressure. I should strive for care that is equitable. Okay, understand the 6 aims of improvement in the healthcare system. Okay. This is just FYI under quality improvement requires. We know that it is a multi-step, it's multi-level, which means it's across the healthcare system, it's across the interdisciplinary healthcare team, Quality improvement is a platform that identifies, it looks for areas for improvement continuously. Quality improvement processes, analyzes protocols that are in place to see if those protocols are working, to see if nurses are adhering to protocols. Quality improvement requires, how does that take place? It requires audits. It requires that we look at outcomes, whether negative or positive outcomes. Also, utilization reviews to identify problems. Not going to be tested per se on to recall those steps, but you need to understand them to be able to answer questions, okay? We're past that knowledge base, that remembering. You need to understand it now so you can apply this information to test questions. And we'll do sample test questions in class. All right, these are some terms that you need to review. You need to understand what an occurrence report is. It's just an incident report. Some hospitals call them different things. Some hospitals may call them a quality improvement report. Some hospitals just plain call them incident reports. I know at Cape Fear Valley, they call them safety improvement reports. And anyone is allowed to complete an occurrence report. If you see something that is not right, you need to speak up, you need to report it, and we need to act upon it. And that's why incident reports are made. Something as simple as a housekeeper can fill out an incident report if that housekeeper comes into the patient's room to clean the room and there's no isolation sign on the door that warrants that housekeeper to wear the appropriate PPE. So therefore, that housekeeper can fill out an incident report. And then guess what? An audit will be done, not an audit, but an investigation will be done. And they would do a PDSA cycle, which we will go through later, again in this PowerPoint. And then we will understand what processes were in place or what steps were missed that isolation sign did not get on the door, potentially exposing that housekeeper to infection, okay? Know what a sentinel event is. Know what a never event, audits, and RCA, which is a root cause analysis. Look up these terms, know the definition of these terms, because I will have probably a significant amount of test questions on sentinel events, okay? So again, here we go again. Why bother? Why am I wasting time digging up all of this information when you can just fill in the information they want to hear? If nurses took that approach or that mindset, then the quality department would never really see the true numbers or the true incidences of cases. And so they would think, well, everything, there's no infection rates that are high because the nurses are not filling out the information or this information is not accurately being reported. So we really don't have anything to improve on. Our numbers look so good. That's not necessarily the case, okay? Don't look at it as just another form to fill out, just another step to comply with. Look at it as this is what I get to do to ensure that my patient has the high quality, safe care. And this slide is just a slide I got off of the American Nurses Association website. It is truly just showing how quality improvement is a continuous cycle in nursing. Not really for testing purposes, but just to have a better understanding that the quality improvement in nursing, nurses have to review the data, they evaluate the nurse's performance. So if there is a problem, let's say, for example, listen well, for example, if there are an increase in medication errors on a particular unit, then what will happen, the nurses that are administering medications will have to be evaluated. So the nurse manager will actually go out on the unit, watch nurses pass medications to see their process. How are these nurses passing medications? Are they utilizing all of the 6 rights? Or are they cutting corners? Are they utilizing all of the references that are in EPIC? So they will have to be evaluated on the performance of passing the medications. Then the nurse manager or can communicate that with the quality improvement department to identify areas for improvement. Maybe the nurses just need to be re-educated on medication administration. They will formulate goals, and then you can see the improvement in patient care or the improvement in the medication administration. And then the data can be reviewed to see if the medication errors have decreased. Does that make sense? So that's how you need to understand that cycle, and you can use any example. I just chose medication administration. But any example here can be inserted here. Think of some of your own examples that you would like to see improved in your clinical areas, okay, as we're doing clinicals this semester. All right, so this is what I really want you to focus on as well. What are core measures? We really didn't talk about core measures in 111, but we really need to have a good working understanding about core measures, okay? So core measures were developed by the Joint Commission as a means to improve quality health care by what? Implementing national standardized protocols. By measuring these protocols, these protocols have to be evidence-based practice to decrease the risk of complications, to prevent these complications from reoccurring, and to overall improve the patient clinical outcome. So again, Joint Commission developed the core measures, and we have core measures in place for several diagnoses, and their core measures are just protocols, steps in place to ensure that every hospital is standardized across the nation. Every hospital should be doing these core measures because it's based on best practice. What is the best practice based on evidence that we can take to take care of patients? For example, patients who are admitted into the hospital for congestive heart failure. What are the evidence-based protocols, measures in place that is across the board that we are taking to take care of patients with heart failure? And every hospital should be doing the same measures because it's best practice. It's based on evidence. Then the Joint Commission can then compare hospitals to see which hospitals are better taking care of patients with, example, congestive heart failure, because they are following this standardized performance measurement system. They are following the core measures. Therefore, they are seeing the best results. Okay, now what I'm going to do in class, I do have several core measures for Cape Fear Valley, because as you know, that is where I work, and we have to sign every year. The nurses have to sign that we have read core measures for these diagnoses that I have listed here. We have read them. We are going to adhere to these core measures, and we understand what they mean, and we're going to ensure that these protocols and practices are in place and that we follow the core measures, okay? And I'll show those in class so you can see what they mean. And we have them for acute MI, congestive heart failure, sepsis, stroke, and I don't have the pregnancy-related conditions because I don't work on the family-centered care area. I don't have one for surgical infections. I don't work on the surgical floor, but I do have one for the deep vein thrombosis as well. Okay, and I will show those in class. So know what core measures are and why core measures are in place. Okay, what are the benefits of core measures? All right, and these core measures, particularly AMI and congestive heart failure, and sepsis as well, but particularly AMI and congestive heart failure for this semester, because in 112 I'm going to be teaching perfusion, and congestive heart failure and AMI falls under perfusion. So if you can understand what the core measures are to treat patients with acute MI and congestive heart failure, you will be ahead of the game, and you will understand what is best practice for these patients and why we do what we do for them. All right, some definitions of benchmarking. You need to know what the standards are, okay? Structured standards, process standards, and outcome standards, those three. Benchmarking is a method that is used to compare performance across hospitals. When I worked in the quality department as an infection preventionist, everything that all of the data that we looked at when we were monitoring the infection rates, monitoring if the core measures were being met, we wanted to know. It meant nothing to us if we didn't have a benchmark to compare ourselves to other hospitals and to make sure we were meeting the goal, we were meeting the mark. Okay, so know what the definition of benchmarking is. Know structured standards, process standards, and outcome standards. Okay. Again, I just got this slide from the American Nurse Association website, and it talked about structured standards. How are we as a structure, as a organization as a whole? Okay. How is the hospital standing as a whole? How do they have the material that the nurses need? Human resources in place. So that's the structure. How is the organization structured in general? Okay, because that plays a big deal with quality improvement. Then the process standards. Are there steps in place to produce a positive outcome? There needs to be processes in place. That's process standard. And then outcome standards. The performance of a process. Did the steps that were actually in place lead to the positive outcome? What was the outcome structure? Know those three definitions, okay? Have a working knowledge of them. Nursing quality indicators. In the quality improvement process or the quality improvement world, there are always indicators that we look at, what we measure, indicators that we measure. We look at patients and we measure their falls, their pressure ulcers. When I say we, I'm using we as meaning the hospital system, we as a hospital system, because you are a part of the hospital system. You are a student nurse. You provide care for a patient. You are liable for your own actions and interventions that you provide for that patient. So you need to always make sure you are providing the highest quality, safe care. So that's why I say we. Are we helping these patients to have this pain assessment? Are we ensuring that we don't use physical restraints, or we use physical restraints as the last resort? And if we do have to restrain the patient, are we monitoring that patient? Are we ensuring that the patient is not getting a health care related or a health care acquired infection? So we look at patient, different indicators for the patient, and we also look at, when I say we, the healthcare system looks at indicators for the staff, okay, that can affect quality. How is the patient-nurse ratio? You don't want to work for a hospital that has a 8 patient to 1 nurse ratio on a step down unit or a high acuity unit. You need to be looking at that. That can affect quality, okay? Look at who you have in your staff mix. Do you have enough nursing assistants in your staff mix? That makes a difference, guys, and you will really see that pretty quickly, especially now that we're going into our 12 hours working on a med-surg floor. It's a busy floor, and if your staff mix, if you have 30 patients on the unit and only 1 nursing assistant, that can affect quality. Okay, so this is just an FYI to help you to still have a better, solid working knowledge of quality improvement. Okay, not going to test you on this, but it just really helps to understand it overall. So again, you remember this slide from 111. The model for improvement is the PDSA. What are we trying to accomplish here? What is the hospital trying to accomplish in quality improvement? How will we know that the protocol or the change is an improvement? What changes can we make that will result in improvement? So we look at this model to help guide us to the answers to those questions. Plan, do, study, act. Plan a change, test it, study it, and act on what we learn. Do it, okay? So that is it in a nutshell. That's why it's a continuous cycle. We can actually make changes in and out of wherever we are in that cycle. We can make changes as they seem to be necessary in that cycle, okay? All right, so what does learn to cuss mean? There is a website. You can go to that website, and it talks about an ambulatory care centers, but it applies across the board for regular acute care hospitals, even long-term care hospitals. But I need to learn to cuss. You need to learn to cuss. And what does that mean? Is saying that I am a registered nurse. I am concerned. There is an issue here, and I'm concerned. I'm uncomfortable. And yes, this is a safety issue. And I'm going to speak up, and I'm going to report it. I'm going to fill out an incident report, occurrence report, a safety improvement report, whatever your facility or hospital call it. I am going to utilize my chain of command because this is a safety issue, okay? And that's what we need to always keep in the back of our mind, and that is going with anything, even to the point that if I see a nurse who I feel like a nurse is under the influence, or the nurse is diverting medications, I am concerned, I am uncomfortable, this is a safety issue. Even if I come into work and I feel like that the nurse-patient ratio is not safe, I am concerned, I am uncomfortable, this is a safety issue. Even when I'm communicating with my doctor that my patient's potassium level is low and this patient needs to get potassium replacement, but yet the doctor does not order it or tells me to write the order, and I know I do not take verbal order. That is not a safe practice, but yet the doctor refuses to enter a computerized physician order entry in the computer system. You know what? I'm going to learn to cuss about that. I am concerned, I am uncomfortable, and this is a safety issue. Low potassium level can lead to my patient having cardiac dysrhythmias, that can lead to cardiac arrest, that can lead to death. So you get the picture. The next 3-4 slides are NCLEX questions. I'm not going to go through the answers. You can read these questions, answer them, and we will discuss them in class along with some other practice questions, okay? I do want to leave you with this. There's a website that you can go to. I challenge you to go to this website just to compare hospitals. It's called medicare.gov/hospital compare. Compare hospitals out there. You guys are actually working in hospitals. You're doing your clinicals in hospitals. Look at hospital compare and see what the quality improvement rates or the safety out there is. The report card is saying out there about quality improvement and safety. That's what hospital compare does. It shows the hospital's report card, so to speak, on how well they are adhering to quality and safety for patients and for their healthcare team. All right, so that concludes this voice PowerPoint. Please email me if you have any questions. We will go through NCLEX style prep questions in class. And I think that's it. And I also will pass out the core measures in class as well. Okay? I'm just going through these to give you answers. But we will go through them in class to make sure you understand them.